Okay, so I think we can call the meeting to order. We were hoping, Jen Chrome had said she could join us. And we were hoping to be able to get some insight from her to help us sort of focus our conversation a little bit around where we think geographically some of the greatest areas of gaps are. But I think we have her information, but she has not joined us yet, so.
I can text her if you want, Lynn.
That'd be awesome. Thank you, Carol. That'd be awesome. Tara, can you just go through who's on the line? I'm sorry, my view isn't showing me everybody.
Sure. We have Patrick, Carrie, Carol, Kathy, and Krista.
Okay.
And Brian is just joining now.
Okay, great. Excellent. So while we're waiting to see if Jen is going to be able to join us, I know we can approve the minutes before I jump in too quickly here from the last meeting, which I'm encouraged when we have a chance to review them. I mean, I think we covered a lot of information last time. And I think this is our third sort of robust meeting. The first one was more of an intro, just talking about, how do we focus our efforts so that we set some targets for us to do some work as opposed to, and actually set some goals for ourselves. But we did have, I think, a great deal of conversation about what training is out there and where opportunities are, which are reflected in the minutes. So if somebody's willing to make a motion to accept the minutes, that would be great.
Yeah, I make a motion to accept.
Thank you.
I'll second.
Second. Thank you. All in favor?
Aye.
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 Anybody opposed? Great, thank you.
Jen is saying she's trying to join.
Okay. Okay. That would be great for her to be able to explain the information. Interesting, just maybe a sort of a segue conversation while we're waiting to see if Jen can get in. In here, I did talk about some of the things that we're trying to do in terms of helping to train staff and some ideas that we've had work on the medical side of our services in terms of our CNA Academy. Interesting, we had a meeting with the villages, just sort of a collaborative meeting to talk with them about, where they see gaps in their service provision to those individuals that they serve who, in addition to the other issues that they have or other trauma-related issues that they have, they also have either intellectual disability or autism. So in talking with them, I think it just validated that while they certainly see a need, and they definitely see a significant difference in the skill set between the staff that they currently have who very appropriately serve their individuals. But when there's a co-occurring issue with autism or intellectual disability, they don't feel that they have the appropriate competencies and skill sets to be able to completely care for them. So I think it was another example of, so they, they're looking at us like, how could you help or what could you do? And I think that's what we talked about last time is, reaching out to those existing service providers in the community who do a lot, but don't have the expertise in autism, and sort of how do you focus our efforts around that area. So I just thought that was sort of a timely discussion. It just happened about a week ago with them. So we agreed that we would kind of reflect on the conversation that we had and figure out how if we could try to, work together to support them so that we would be increasing the impact to individuals with autism without, trying to either replicate or have a bricks and mortar kind of project going on with an existing provider. So I think there does appear to be interest for that kind of relationship. So that way we leverage the skills that, one organization has to help kind of boost the resources another has. So anyway.
Can I just ask who, I'm not familiar with the villages other than the one in Florida, and I'm assuming that's not
Oh,
what
I'm
you're
sorry,
talking
no.
about?
I definitely did not talk with them.
Just checking.
Thank you for that clarification. For the Village in Hartford for Children, I'm sorry, I'm probably butchering their official
That's
name.
okay.
Yes.
And what is it? What
So
is it?
they provide community-based services and some residential services to individual children who have, trauma-related psychosocial, psychiatric, behavioral issues.
Okay,
Yeah.
thank you. So probably more
Sure.
DCF and DMIS.
Yes, absolutely,
Okay.
DCF, yes.
Thank
Thanks
you.
for that clarifying question.
I was picturing golf carts, and I knew I was going down the wrong road.
Okay, funny. Okay, so Jen says computer had updates this morning. It's the first time joining Zoom, so here she comes. Excellent. We delayed long enough to have her present her own information. Jen, can you hear us?
I can. I'm on my phone though, so I'm not going to join the video.
Okay, so do you have your information available, the data that you could kind of high level go through that with us? I'll tell you what we're trying to accomplish, at least, and others, please jump in. I don't want to monopolize, but just that, what we've been talking about is where are there needs for education and training of professionals? And obviously that's a very broad and deep conversation. And as we came up with this huge list of opportunities, we thought it made sense to try to look at the work that we're doing up against the service areas that you report out on, to learn from you where you see geographically and maybe competency wise where the biggest gaps are from your perspective at Carillon. Does that help?
Yes. So I do know as part of our performance targets this past year, we had multiple training initiatives. I know I was engaged in doing 3 different training series for the DCF Training Academy, a high level overview of what autism is, along with a presentation of life on the spectrum with a few panelists, one a parent, one a provider, and an individual with autism. And then the third part of that series is sharing resources through state plan services, care coordination, as well as the Department of Social Services waiver program and the Department of Developmental Services Children's Services Unit. So that's one training that I provide. I also provide a training every quarter to the mobile crisis teams across the state, and that's been going on for almost 8 years now. We've been doing trainings for them every quarter since they do have some pretty high turnover. We've also done some trainings, that same training on what is autism and high-level interventions for in crisis, both for the State Police Academy and CHDI. I think as part of our ongoing conversations within Carillon and other entities over this past year, we still see a need for more training for our ECCs. The clinicians in ECCs, a lot of our individuals, at least on Medicaid, go to those ECCs for medication management, where they also require talk therapy as part of that medication management, which is a challenge for obviously our individuals who are nonverbal, but also teaching those clinicians there that talk therapy could be with, family therapy or play therapy or other types of therapy, not traditional talk therapy for these individuals. So we're trying to diversify the group of people who are able to meet those needs, both for medication management reasons, but also for, step down from intensive in-home services to something a little less intensive, more traditional outpatient type services. So trying to train licensed clinicians on base level interventions or working with individuals on the spectrum. There was also a training that I was part of organizing this past year on suicide prevention, specific to individuals on the spectrum. We had Lisa Morgan, who is an adult with autism and has utilized adult crisis services for her own suicide ideation and suicide in her family. So that was really very informative. I don't think we've taken the lens of, that level of crisis intervention for individuals on the spectrum or intellectual disability. So that one was really beneficial. But I think the more people that can be informed, even in basic skills in working with autism, in my private practice, I always say, yes, I need to have a diagnosis for a CPT code for insurance reasons, right? But very rarely am I treating autism. I'm usually treating the anxiety, the social stuff, the depression, other stuff that's going on with an autism diagnosis. So I think helping other licensed clinicians understand that would be beneficial. I see Brian on here too, more training for, teachers is always beneficial too. Our special education teachers, my sister is one of them. So I know how spread thin she is, working in her school district with her kiddos with special needs, and having, more global understanding within the school systems of how to support those individuals outside of their IEP and, traditional supports. So that's my little soapbox.
In terms of the folks that Carillon services, and I know when you go over the data, you talk about where there are providers and where there are gaps in providers. Are you able to speak to sort of geographically? I think I can recall some of the discussion, but where you see the greatest need and in what discipline, what areas?
So specific to the in-home ABA services or behavioral services that we oversee, Region 3, which is that region along the border of Rhode Island, we have maybe 3 providers in that entire region. And while it's less densely populated there for sure, we still have a lot of individuals with significant needs in that area of the state. The other challenging area of the state is the very southwest corner of Connecticut, headed towards New York. And that's more not necessarily because we have fewer providers, and we certainly have a ton of kiddos down there, but traffic really limits providers from seeing multiple people in one day. So for in-home services, that is a challenge. A lot of providers in that area of the state are actually moving more towards clinic-based services or center-based services, so that people are coming to them rather than having BCBAs and licensed clinicians and BTs traveling all over that region with the traffic challenges. We will always need more bilingual, both clinicians, BCBAs, and behavior technicians. That's always been a challenge for us across the state, and not just in Spanish. We actually have a very diverse Medicaid population who speak a variety of different languages. So that's part of where we're struggling in terms of ABA providers. I think too, Tara and I talked about this a little bit, that the other challenges that I think we need to talk at the advisory council level are the different levels of care available to individuals with autism, right? So Lynn, you guys have your wonderful inpatient and PHP programs, but there's nothing in between that and in-home behavioral supports, right? So if you have a traditional mental health diagnosis, you have inpatient IOP, PHP, EDT, a whole different variety of outpatient intensities. All our kids have, all of our individuals have, is inpatient. Some have ability to go to the PHP program with you guys in New Britain, Lynn, but that's really the only game in town for PHP. And then in-home services. So, I think when Tara and I were speaking, and I do have data that I could pull together at another time, this committee has seen the ED stuck data for our individuals with an autism diagnosis, and how much longer they stay stuck in the emergency room awaiting another level of care that's appropriate to receive them out of the emergency room. The same thing happens, Lynn, when we've presented PAR data for the hospital for you guys, you have longer lengths of stay waiting for services to be ready post-discharge.
Right.
And a lot of times they're no longer meeting that level of care and do need to be discharged back home to a setting where there's not necessarily the supports that are required. So I think that's where we look at, having more licensed clinicians able to receive those individuals, even if it's at, 1 or 2 times a week outpatient services, to kind of bridge that gap while we're waiting for those in-home services. There's a lot of holes in the system.
I have another question, but I want to see if others have a question as well. Anybody? With regard to the outpatient services, Jen, are there any other, well, I know Clifford Beers is one, but I know that there are, I call them sort of boutique services that, serve individuals, but many of them don't take Medicaid. So are there, is it that there are not clinics set up to take Medicaid, or what do you think the barrier is to replicating some of the work we do? Although we, clearly transportation is an issue we talked about last time. Even PHP is difficult because it requires such a commitment on the parent's behalf. And that's why we talked last time about, we've been reaching out to school systems to see their appetite to work with us to be able to support the kids within their school setting, and what that model might look like. I mean, that's for, the very high acuity kid. And that doesn't as much address maybe what's happening, with once the kid actually hits an ER, or needs our inpatient level of care. But I wonder what you know about that.
I did meet with Dr. Saul and his team over at the Institute of Living. Tara, I gave him your contact information too. So I hope he reached out to you. They have a small but mighty outpatient clinic for medication management. They do diagnostic evaluations, and they are really working to service the lifespan. So Dr. Saul is their adult psychiatrist. Forgive me, I cannot remember the name of the woman who is their child psychiatrist there, but they also then have social work, an APRN, and a researcher there. So that's currently just outpatient services. I know they shared with me that kind of their 5-year plan is to offer other levels of care. It's more a matter of, as you all know, funding and finding space on their campus to be able to do that. To which I then responded saying, well, gosh, Harvard Healthcare is all over the state. Wouldn't it be great to also have other satellite offices offering the same thing across areas of the state? Because, it's great to have it in Hartford and Hospital for Special Care in New Britain, and Yale does some diagnostic evaluations for us as well. But that's really it for those higher levels of care for us.
Thank you.
Yeah.
Just last question, Jen. So within the gaps that you talked about, would you say is it equally distributed across the different levels or different disciplines, or is it more paras or BCBAs? Where do you see the greatest need for? Because one of the things this committee is working on is figuring out, what existing training certification programs are there? How can we partner with the, universities, like Southern's, University of St. Joe's, where do we enter and try to have an impact as opposed to try to, just kind of touch every area of need? Where's the greatest need from your perspective?
Well, I think we're very lucky in Connecticut that our Medicaid program will authorize services both for the BCBAs and for licensed clinicians. In other states, they only allow the BCBAs. So I'm thankful that we also are allowed to enroll licensed clinicians who have training and expertise in the area of working with individuals with autism. But the fact of the matter is, if I enrolled every BCBA in the state of Connecticut, I still wouldn't have enough BCBAs.
Okay.
So I do think more training programs for master's level clinicians for, to get that BCBA. I know DSS is in the final stages. I think, Tara, maybe you could speak more to this, of looking at the qualifications and changing the qualifications for the behavior technicians. I know that's been a challenge since the beginning of this program back in 2015, and looking to align it more with the Department of Developmental Services high school diploma qualifications. So that may help. Truly, the behavior technicians, it's a high burnout job. They're working crappy hours, after school hours, evenings, weekends, getting beaten up. Carol, you as a provider, you could probably speak even more to that than I can, but it's not easy work that the technicians are doing. It's a high turnover. It's fee for service. So if a kid goes into the emergency room or inpatient, they lose those hours that they're working with that individual. Oftentimes that staff needs to be transitioned to another individual so that they can keep their job. There's a lot of challenges in running, a fee for service program like that. I do know our providers who have center-based services have a higher retention of their behavior technicians, because I think they can report there for kind of a 40-hour traditional kind of week, maybe not traditional hours, maybe like a second shift kind of week, but they do have a higher retention of staff than our providers who are only doing in-home services.
Jennifer,
Harry has a question.
yeah, I just wanted to comment. I know that there's a deficit of BCBAs. I think there's a likelihood that that could become even more problematic in the future. The BACB is changing their requirements, and they're going to be looking for graduate programs to become accredited.
Yes.
I know that that's going to be a hardship for many graduate programs.
Yep.
Especially the online programs. And so that may actually be a barrier in the future as well.
Yeah.
Jennifer, can I ask you a little bit about your perception of special education teachers? Because from my perspective, I actually have a harder time recruiting special ed teachers with experience working with children with autism than BCBAs.
So it's hard for me to speak to the school systems. I don't oversee autism services in the school system, so I can speak based on what I hear from families we work with. Are you talking, paraprofessional level support?
No, I'm talking about certified special education teachers.
Sure. I don't know if Brian's able maybe to answer that a little bit better than I am, as being the Department of Ed person here.
Hi, Brian.
Hey, Patrick, how are you? Yeah, obviously we have significant vacancies across the state in special education, both non-certified and certified special ed teachers, specifically in working with and supporting students with autism. Those are particularly challenging vacancies to fill. We have a variety of strategies to assist districts and programs with hiring, but there's been discussions around onboarding and, the concept of micro-credentialing in those concepts. As you know, we have one certification in Connecticut to serve students across the spectrum, ages 3 through 22. Other states have, different levels of intensity or various specific areas of certification. There are pros and cons to both. But, the need to, I always kind of refer back to where I started my career in working in private special education programs. There's that onboarding and training even before you're in front of students. So I know that ed prep programs don't necessarily provide that level of, depth and specificity, in working with different populations. So, and we always say that certification, you could be working with students with learning disabilities, and teaching reading, or students aged 18 to 22, working more on community-based services, or working with nonverbal, students with autism. And the skill sets are very different for those, but the certification's all the same. So we do have training, obviously, and support in those areas, but I know I see, Kim's on as well, who, oversees and manages special education programming and supporting the districts, but it's a huge challenge.
Harry, you had your hand up.
Thanks, Lynn. I guess I would ask, the group, maybe. I know when you asked this question of Jen in terms of where are the greatest needs in identifying the gaps with respect to providers, Jen, your response was really about more training programs for BCBAs. But in fact, and correct me if I'm wrong, the greatest number of providers that are approved currently are BCBAs. I think we have a dearth of providers across disciplines, and I don't think that BCBAs are the panacea. I think that if we had individuals from the autism community here too, they would say that it isn't a one size fits all, and not everyone
It's not.
not everyone sees BCBAs as the need that as filling the needs that they have. So
Yes.
I think that we have to think about this more from a preventative approach as opposed to a responsive intervention piece. And I think that does start, I think we have the greatest opportunities. I mean, granted, my bias is I'm an educational psychologist with clinical training and neuropsych training and so forth, but seeing that children exist within schools and families interact with schools, caregivers interact with schools. We have the greatest opportunity, and schools are, obviously education is compulsory in our state. So we have the greatest opportunities to make those preventative inroads in those settings. So I personally think that it is short-sighted for us to think about this from the standpoint of waiting for the crises to arise and then thinking how we treat the crises and who we train to treat the crises. I think we have to do a both approach, right? Like we have to look at how we can prevent those mental health crises from surfacing and how we can support families and individuals with autism as they are developing and through that throughout their development, so that we don't have as large of a need for the crisis intervention and providers at that end.
I totally agree, Carrie. I think, educational programs that train OT, PT, speech, special education, regular psychology majors all need more training in working with individuals with an autism spectrum disorder as well as an intellectual disability. Because the fact of the matter is it's always a multidisciplinary approach working with kiddos with this many complexities. And I think it's unfortunate. I push back a lot actually when we have recommendations, whether it's from DCF or school or whatever, and they say, well, this kid has autism, therefore they have to have in-home ABA services. And I push back sometimes saying, in-home ABA isn't going to help this child be less sensitive to taking a shower and having a meltdown every time they take a shower. Let's get an OT in there. Those are the people who are brilliant in coming up with strategies there. And definitely having that multidisciplinary approach is so helpful, especially for families. And I wish that we were able to, like the birth to 3 model, where it's not all a la carte, really is nice. I mean, that's the scariest part of that transition for families leaving birth to 3. They have to go to this a la carte insurance services where they have to find their own OT, find their own speech, find their own ABA provider, whatever, medication management, where in birth to 3, it's all under one umbrella in one house managed by a case manager. I do think that there's huge benefits for that, especially for our more complex kiddos. And even the less complex ones. I don't think it's just because they're complexities that they need that. I think every kid benefits from an occupational therapist. They come up with some brilliant stuff.
Right. And I think it's in how you define complexity too.
Right.
There
Exactly.
are individuals who aren't necessarily identified with having, complex issues and yet are incredibly dimensional, complex individual. They don't have diagnoses that are, that would identify them as being complex, but certainly their experiences are complex and not necessarily well understood by all. So, I think you can have an individual who has is identified as being on the spectrum, but doesn't have an intellectual disability, doesn't necessarily have a defined mental health challenge, but is inherently complex because they look at the world through a different lens. And this is where I think we could improve our collective approach to preventing those mental health challenges and other associated challenges from arising by better equipping the educators, the support personnel, the families, et cetera, the local community members, right? So that it is, there's a greater shared understanding through, and I think, Brian, you mentioned sort of micro-credentialing. We talked about this in another group recently, but ways by which we can equip people who don't necessarily need to have a bachelor's and a master's and so on, but they have basic understandings that allow them to facilitate growth and change in individuals, even in terms of social interactions within communities, right? So I think, labeling people with clinical terms sometimes is facilitative, but in other ways, sometimes it is condemning. So I think I really am of the opinion that we need to look for ways that start really early in identifying small changes we can make within the systems that currently exist, as opposed to creating more training programs that are doing more of the same to address that. I don't think that's innovative, and I don't think that necessarily attacks the underlying challenges that currently exist. But maybe I'm in the minority with respect to my opinion on that.
Yeah. Two thoughts on that. One is, can somebody describe, I'm sorry, I've heard the term, but can somebody define micro-credentialing?
Yeah, I don't mind jumping in here. Just so certain states or other entities have micro-credentialing as a certification area. So just using as an example, a little more broad term, but in Massachusetts, they have certification for working with students with intensive needs. I forget what the exact term is that they use. So there's specially designed training to work with students who are more have additional challenges versus more of a general area. And so you can get very fine-tuned with a micro-credential, saying, working with students with autism, for example, we know there's a wide spectrum, right? So even within that, there are some challenges, but secondary transition's another example, having folks make sure that they're trained and understand the basic laws and procedures and regulations around secondary transition if they're working with older populations. And so there's specialized criteria, I suppose. It's come up, for example, with dyslexia as well, working with students with dyslexia, having specific training in reading instruction, structured literacy, and then having that, like, I have a micro-credential in that area, and then they're better prepared to work with that student population versus a, superintendent saying, I have a special ed certified teacher, I'm going to place them next year to work with X population. Whether or not they have experience or training, they're certified to support that group.
Got it. Okay, thank you. That's helpful.
But it was a long-winded answer, but
no, that's helpful because I've heard the term, but I really could not define what it was. Carrie, I like what you were saying about, I think we don't need to recreate the wheel. What we're trying to do is sort of leverage something that's currently working. It might not be in the autism field, but it's a concept or approach like Brian is describing that's currently working. And I think obviously almost all of the kids and we're not just talking about kids, obviously we're these adults, the kids grow up, but for the moment, the kids that we're talking about who have to go to school, should be in a school, that's where they're spending most of their time, right? So how can we partner is how I'm looking at this. With the schools, or, is there some innovative program? Because obviously each district is very different. And as we're out there talking to people, there's some folks that are huge appetite to talk with us about how we might partner and what might that look like. And others who were, the first thing always comes to mind is budgets. So, great partnering is like, yeah, you guys come on in and do it, right? Because we need you, but we don't have any way to support you, right? So I wonder if there's any, if anybody on the call, has an example of something that they think we could model and replicate, because then that's where we're going to be able to have our biggest impact. Well, there's our challenge.
Are you asking if anybody's doing something well in terms of collaborating between clinical spaces and education spaces?
Yeah.
I mean, I would defer to Brian or folks who work in the State Department of Education to identify whether there are things that are, there are exemplary programs that exist. I mean, I think there are, I'm sure there are examples out there where people are doing things well, where things, certainly it's in district's best interest to keep their even from a budgetary standpoint, to keep their kids within, insofar as they have folks who are well equipped to address the needs of the students that they have. Now, do you need a clinician to come in and tell you how to do that? No, not necessarily, but you do need proper training and solid understandings of what are the empirically based, interventions and ways by which to best leverage kids' skills to compensate for whatever their challenges is, whether they have autism or anything else for that matter. So I think that there are probably schools that are doing things well and we don't hear about them necessarily, but maybe Brian knows of some examples. And the reason we don't hear about them is because it's not a problem. Right? We are more likely to hear about where things are going especially poorly. And that's just the way the world works, I think. But I'd love to know, because I would love to go. And I think unfortunately, there are, unfortunately or fortunately, there are schools that maybe aren't public schools where they are doing things well also, and we don't know about that because they are separate from and isolated from, and again, pros and cons to everything associated with that. Those kids are not with their non-identified peers, and so they don't get those opportunities. And is there an exceptional program, Brian? I don't know. Can you identify something where things are going extremely well so that we could more of the same?
I think you summarized it nicely. I mean, basically, what you hear and see in the media and, the themes out there are all really negative when it comes to special education. So, we've been trying to the extent possible of sharing news and the great work that's happening and model programming. Some of the CSD legislature this year on some of the successful foundations that the RESC Alliance have shared with us, where districts are coming together as collaboratives to share resources, to provide services for, challenging or populations of students that may not be meeting with success in the general education setting. So last year, we kind of posed to our special education director, if there's something that you're proud of or that you would like us to see, sort of the opposite of us monitoring, based on an area of concern. And many districts reached out and shared their programming. So I have a list of programs that we visited last year and folks that, that are proud of their work and their training. And we saw some really wonderful environments where they're not having issues with staff turnover. Their cultures are, thriving in really challenging populations of students. And so trying to capture that and share it out, I think, is the next step in highlighting some of those different pieces and replicating that work across. But it takes a support at the leadership level, especially the building principal that is, managing or overseeing that in collaboration with the special education director.
I think it's a fantastic way to do it. Then I think what
Yeah.
Brian has just said with respect to like inviting people to sort of
Yeah.
identify and share their points of pride and say, this is how it works here. Now, granted, there are lots of different variables that are going to be
Right.
different from district to district, school to school, et cetera. But at least you
Yeah.
could perhaps, cull from whatever the, repository is that you have assembled, some ideas that might be applicable or transferable or, be able to be generalized or give rise to independent new thoughts. The other thing that I was going to say, which just sort of flew out of my head, was, I think as an example of what I see as a real strength for schools is being able to identify what they're doing well and also what their real evidence need is and defining that in clear terms, then seeking out. So I'll give this as an example. I'm thinking of a very specific example as it relates to Southern. We are currently working with a district who in their transition program said, we have students, they're not kids because they're in the 18 to 22 population, young adults who do not have an intellectual disability, probably academically are college capable, but they certainly need a fair amount of support in order to be successful and navigate the landscape of higher ed. Can we kind of build this bridge? Can you work with us? And that is reaching in to, a different entity, in this case, our university, and saying, hey, do you have the resources? Can we think through this, and grapple with this problem together? And can we strategize as to what's needed? And it's kind of building the plane as you're flying it, but it means that that you get a good sense of what the general problem is, and you try to strategize as best as you can. Inevitably, there are little problems that bubble up along the way, but then you learn, and there is sort of an iterative process, right, that you then design. I think that's the way to solve any complex problem, potentially offers the greatest potential, is going into it and being able to cull from different resources and constantly sort of reevaluating the process, as opposed to saying, this works here, it's going to work everywhere. I think that's, what I mean? It's none of us actually believes that that's true. So I think it is about an ongoing iterative process, ongoing conversations that really actively engage people from different disciplines, looking at what they can do in terms of moving things forward, but looking at what is the presenting problem right here, because we can't be all things to all people, but identifying one solid, clear problem and then trying to address that.
The example you just gave, we don't want to forget about the young adults and the adults. Yana's chirping in my ear right now, and as she should be, right? Because we know, like I said, these individuals grow up and they're the opportunities they have for needing support, are going to continue. They may look a little bit different, but they're going to need support, as Yana said, right? And so thinking about, that, I don't want us to lose sight of that. And I think the other thing is, how does this work? These conversations that we're having, I almost think of it like a feasibility study. I don't know, another grappling with the term, but I know when we first opened our program here many years ago, what we did was take all this information that we had and say, where the heck do we enter, right? Their need was massive. So how do we start, somewhere small and then build on that? And, that's a pragmatic approach to doing it. This is a much bigger challenge. Obviously, we're talking about the statewide issues here, but I think as we talk about it, thinking about the folks who are with the IQs over 70. So that's one of the issues. The young adults is another issue. And then I think, how do we use this conversation that we're having to help shape our legislative agenda? Because that's one of the things we talked about at the broader council meeting, was remembering that in January, the session's going to start. And if we ask for everything, we're going to, and we will likely end up with not much, or it'll be very diluted. And I think we talked a little bit about that at the council meeting, what is the priority here? And I don't think that's necessarily this group's role, but I think if we can bring it back to the next council meeting and share some of the conversation that we had and get the feedback from, you know, that broader group, it might seem like a somewhat logical next step. I'd love to hear from other people who haven't maybe spoken yet. Does that make sense? I mean, we could meet, and people have been great about meeting. I think we've had really good attendance at this, but I want to make sure that we get to a point where we have something that's actionable. Even if it seems smaller than we'd like it to. I think we're all have these lofty goals, and so I think we have to just start somewhere to move us from conversation to action. So.
And also, I will add as the voice of OPM, if this is a budget year.
Yeah.
So, you know, a lot of people are going to be advocating for, you know, a limited amount of resources. So anything that we can do to, you know, within current programming, to help improve the system, or within, you know, how we leverage current resources, I think is an important part of this conversation too, as we move into, you know, this year.
Tara, are you able to share it all with this group, and maybe not based on where it is in the approval process, but the proposal from the Department of Social Services to make some changes to state plan services?
Yeah, I will get an update. It's been a little bit since I've heard back on that, so I'll get an update on that and get back to the group. I already wrote that on my to-do list.
Okay.
I thought last I heard it was kind of like a done deal, but I haven't seen the final.
Yeah, last I heard it was going to you guys over at OPM, so.
Okay, I'll find out where it is.
Okay.
I
Sorry,
was
Kim.
thinking, no, that's okay, Tara. I was thinking that would be a very helpful place to start, is to see what is being proposed by the administrative organizations themselves, so that we're not working counterintuitive
Yeah.
to that, and being thoughtful to their proposals. And to your point, I hate to say it this way, but it always comes down to money. And I think if we were thoughtful about the items that could leverage the funding sources, I mean, really, ultimately, you know, specifically for this population, I think the funding sources have been really the linchpin. And if we could maybe consider, how can we talk about flexible funding sources as part of that agenda? To me, I think that would be a game changer if we could talk to legislators about how we can open up those conversations.
What would be a low-hanging fruit, you know, from my perspective at Carillon? One of the big barriers that I know my care coordinators work up against every day, outside of connecting to an ABA provider, is the medication management piece. And we know that when individuals are not stable on medication, everything else tends to fall apart. And really having that rule, and I don't know if it's changing the structure of how clinics do their billing, or, you know, I don't know enough about that to speak to that, but requiring talk therapy from a untrained or uninformed clinician just because it needs to happen, first of all, is a complete waste of families' times, and is not actually beneficial. So I don't know if it could be more, you know, if the child has a treating provider, meaning an ABA in-home provider who's seen them, 40 hours a week, isn't that more informative and beneficial to the psychiatrist prescribing medication than a clinician who might see them for 45 minutes every 2 weeks and isn't informed in autism? Sorry.
No, it's okay, Jennifer. You're singing my song right now. And actually, I'm going to speak as a parent for the moment, and that has been the number one issue for me, because I could potentially keep my daughter from even needing to go on the waiver If we could think more thoughtfully about the fact that actually we have a Connecticut law that caps in-home BCBA services at age 21.
Yep.
And that's a big issue because now you're forcing my hand to go on the waiver for my daughter just because you didn't allow me to use my private pay insurance to do the very service that has been the most successful for her. That seems silly to me. And so that's a very big example of how we could think more thoughtfully about this. And I'm not saying it's the sum and total of the adult services that could really make or break her situation, because there's other services that honestly need to become a part of the situation. But it is a prime example. And if we could talk about how we could look at things in a more flexible direction rather than only one way to seek these services, so that families like me that have a little more means, I don't have to seek those services in the same way as families that have no choice. Those are the means. So then I'm taking away from a system from families that need more.
It's a great point. And I think both this point, Jennifer's point that you sort of underscored with your example, and thank you for sharing that, Kim, is that it should, if we could in any way move the needle on allowing families to make informed decisions about what are the things that work for, or adults with autism, could make decisions about what are the things that work best for them, and have that, whether it's linked to that flexible spending. Also, the piece that I will come back to is that, Lynn, you mentioned earlier the IQ of 70, such a ridiculously arbitrary number, particularly when it comes to this population. And this is another thing, and it just speaks to, and I don't say this in a way that's insulting, I just mean that people don't have, it just speaks to sort of the ignorance that people have with respect to a lack of understanding what really are the things that challenge this population. So if we can in any way change some of those things,
which has been
changed very
certainly not a
practically.
new discussion, right? Just one we need to execute on. So we'll put that on the priority list. Carol, you had your hand up, I think.
Yeah, I just wanted to comment on something that Jen was talking about, if it was Jen or Carrie, about the idea that you have to, in order to access certain services, you have to be a part of that organization and accept services from that organization that not only, I'll go one step further than saying they're not helpful, they may actually be harmful. So assuming, forcing an individual to take a therapist that is not skilled in working with someone with autism. I know personally, we're in Enfield. We've actually made some inroads with CHR, which has been great. Initially, we would get a client, we would refer them to CHR for medication management, and then CHR would tell them, you can't go back and see care, you can't see interlocking anymore. You have to terminate those services. And we were actually able to work with some of the administration from CHR, and actually they're doing reverse referrals now. They're getting someone for medication, and they've made some changes with their stuff, internal policies, to be able to allow people to be referred to us from CHR. So I just want to kind of shout out to CHR a little bit about being flexible for that, but also that's because there were dialogues and conversations, and families are willing to kind of make those make those statements, that we're able to be a little more flexible around what our people need, as opposed to what's more practical for an organization.
Good to know, Carol. The other really low-hanging fruit too, I think, it was a great idea at the time during COVID to extend the age for IEP coverage to 22, but that also has now created a huge gap in Medicaid or insurance funding services being done at 21, and then really nothing except maybe a little bit of transition services from school age 21 to 22, but no clinical services until they turn 22 with DDS, if they are DDS eligible. It's another huge gap that could be low hanging fruit. You know, that I think that's change in language. I don't even know that it would take that much extra funding to have, you know, a few of those kids who really require those services from 21 to 22 through insurance or whichever direction we end up looking at it. But I'm just trying to think of some low hanging fruits that we can have some successes on this team.
Mhm. That's a great idea. You know, I've noticed that we have not had families participating in public comment, and I'm not sure why that is. I don't know if others, I mean, I can't recall the last time somebody has done that. It's been quite a while. I think it's so powerful. I know sometimes, you know, it's a very individualized story, which of course matters a lot to them. And it doesn't always seem particularly germane to the work that we're doing, but I'm thinking, you know, there's a lot of parents on this council, and I think either us sharing our, you know, life experience with this, and encouraging others to do that, I think is also really important. I think particularly when we get into session and you've got folks listening in, I think it's a really powerful voice, and it doesn't always, you know, it represents. Many of us are providers and parents, but I think it seems to have been a little diminished, and I'm not really sure why. I don't think it's intentional at all. I think not being there in person, I think some people actually like to come up and listen in and participate in person, but it's just an observation. I apologize, guys. I have a 4 o'clock meeting, but thanks for everybody's participation. I think, and Jen, thanks for jumping on. I think you gave us a lot of good insight.
Sure. I apologize for my technology challenges.
No, you're fine. I just want to mention too, I did send out a survey link
Yeah.
today earlier for legislative proposals and ideas for council members. So if you guys have a chance to fill that out, that would be helpful. Thank you.
Great. Thanks, everyone.
Right.
Thank you. Take
Enjoy
care,
the
folks.
Indian summer.
Yeah.